Welcome to the Medical Forum podcast. This is general information for health practitioners only, and you can claim the time as part of your CPD. Yeah, well, welcome back to the Medical Forum podcast with myself, Dr. Joe Kostrich, GP and Clinical Editor of Medical Forum. And today, very pleased to welcome back Dr. Saud Hamza, but also we have today Dr. Sanjana Kondola and Associate Professor Kim Mina. Welcome all to the podcast and thank you for coming in today. Now, we're going to be talking about breast genetic testing and its impact on decision making. And I'm really looking forward to this because it's a topic I know next to nothing about, and I suspect that I may not be the only one. But before we do get into it, I'd like to quickly go around and to each of you, just tell us a little bit about your background, how you've come to be doing what you're doing at the moment. Maybe Kim, if you'd like to go first.
Sure. Thanks, Joe. I'm a genetic pathologist, which is actually a specialty that didn't even exist when I was in medical school. So it's not something that I necessarily anticipated I would be doing. I did my medical training here in WA and also did my genetic pathology training here as well. But I've moved around and worked on the eastern states and also in New Zealand for a bit as well in pathology. I guess on a day-to-day basis, I'm clinically responsible for a laboratory that performs genetic testing, including the inherited breast and ovarian cancer. And I'm heavily involved in how we analyse the data from that testing and put it into a diagnostic report that goes back to my colleagues.
Okay. Sanjana.
Thanks, Joe. So my name is Sanjana. I'm a medical oncologist. I trained in England and did my advanced training in WA. My dad died of cancer, so that was my driver to become a medical oncologist. I thought that cancer care was often impersonal and patients became a number, and I wanted to change that. So I am very passionate about delivering patient-centered, holistic care, taking into account patients' beliefs and their values and their wishes. And I think that changes their journey. And I'm extremely passionate about managing breast cancer. It's one of my key areas of interest. So thank you for having me.
Pleasure.
Thanks, Joe. I'm Saud Hamza. I'm a breast surgeon, and I had my primary medical degree from Baghdad. I'm from Iraq originally, and I did my surgical training in Baghdad and in Ireland, and I came here to Australia about 20 years ago. I did my fellowship training here and then post-fellowship advanced training in breast, actually in Australia and in Milan in Italy at the European Institute of Oncology. And I really like breast. I've chose to be a breast surgeon because I think breast is the subspecialty in which the multidisciplinary team, is really highly defined in this area. So I really enjoy working within a team, and I think this environment, like a teamwork, deliver always the best care to the patient.
Look, I think that's true. And you mentioned, Kim, about genetics in medical school, and I remember I think we had about 1 hour on it or something like that. And certainly everybody was siloed. I mean, this concept of teams was something that was occasionally floated, but given nothing more than lip service. So I think that all three of you here, talking about the same issue from different directions really does show how the practice of medicine is evolving. And to your point, Sanjana, patient-centred. And it's also sometimes a buzzword, but really taking into account what does matter to the individual who ultimately is on the receiving end. But Kim, to open this up, there's a new MBS code for genetic testing. Tell us a little bit about what the changes are in terms of the guidelines, or perhaps not so much the MBS item, but more what has changed in terms of what is being recommended, and what do we need to know about some of these tests?
Yeah. So for context, we've had a Medicare item for inherited breast and ovarian cancer diagnostic testing since it was November 2017 when it first came in. So we've actually had it for almost 9 years now. Yeah. It's always been a requirement of that item that patients are estimated at being at least 10% prior risk, so before testing, of having a variant in a gene that's associated with breast and ovarian cancer. Back in the day, the way you assessed that 10% was with a couple of calculators that pulled together information on patient age at diagnosis, family history and tumour characteristics, and generated a score that would then determine whether that patient met that risk threshold or not. But what we know now is that there are some patients that wouldn't achieve that 10% using those calculators, but in reality are definitely at 10% risk of having a variant in one of those genes that we test for.
Right.
So we're talking about patients, for example, a patient with breast cancer aged between 40 and 50, males with breast cancer, a patient with triple negative breast cancer. They would automatically all be considered to be at least 10% risk of having a variant in a gene. They wouldn't necessarily, without family history information, have previously qualified to be eligible for that item. So what's changed essentially is there's a bigger population of patients
It's been
that are
opened
now
out to a
eligible.
greater pool.
Yeah.
Okay.
Yeah.
So the score test or the algorithm was missing people. Now there are some additional factors that allow the person to qualify?
I think it's just that we've loosened some of those requirements to be eligible. So it used to be very heavily based on family history, and we now know that there are patients that are going to have a germline variant in one of these genes that won't necessarily be aware of a family history. So it's really opened up the testing to a broader population of patients.
Okay, so if I'm sitting in the surgery, a GP sitting in the surgery, and somebody comes in and says, I'm interested in having testing, what sort of process do I need to follow to assess their risk? There's an online tool that enables me to do this risk calculation?
There's still those online calculators that you can use, absolutely. But EVQ are an organisation that actually published a list of guidance as to who might be eligible for testing. So you could work through that with your patient and determine whether that might be something that's appropriate for them.
Okay. And there's talk also that these tests, or maybe talk's not the right word, potentially beyond ovarian and breast cancer?
Yeah, sure. So most patients that come in for this sort of testing, we're trying to understand whether there is a genetic susceptibility that explains why they've developed breast or ovarian cancer, and that's how the item is used. But many of the genes that we test, so the testing is done now by gene panel, so it'll be BRCA1 and BRCA2, but other genes as well associated with breast and ovarian cancer. What we know, though, is that some of those genes, including BRCA1 and BRCA2, are associated with an increased risk of other cancer types other than breast and ovarian. The common two are prostate and pancreatic cancer. So when you identify a patient with a variant in one of these genes, you're not only explaining perhaps why they've got the current cancer that they do, but also identifying a risk of other cancers in future.
Okay.
There's also an overlap. So some of the genes associated with ovarian cancer are also associated with Lynch syndrome, which is you'd possibly be aware of an increased colorectal cancer risk over lifetime.
One of these terms that rings a bell in your mind. You've heard it somewhere before.
So you've explained why they might have been at increased risk of the ovarian cancer, but you've also then identified they're at risk of other cancers associated with Lynch syndrome, so colorectal, endometrial cancer and so forth.
Sanjana, beyond risk, and this is really to me very fascinating, again, thinking about how little I learned about genetics. This is not just now about identifying risk, but it's actually also guiding treatment. I mean, tell us a little bit about that. And in particular, again, a term I'm not particularly familiar with, PARP or PARP inhibitors.
I'll start off by just saying initially oncology and the treatments were guided by the organ of origin of the cancer. So we treated breast cancers years ago very similarly. So kind of the genetic testing has now taken us into a realm of precision medicine, where we're looking at getting treatments that are dictated by these unique genetic profiles in
A very
tumours.
personalised approach.
It is. Okay. And so we can use this frontline. If we use it frontline, it allows us to select targeted treatments. It also looks at predicting what the disease recurrence will be in patients. And we can actually avoid very toxic and unnecessary treatments. This has led to kind of a paradigm shift. So it has changed our clinical workflows. It has changed our optimal care pathways for breast cancer and other cancers. And we've had an accelerated drug development and fast-paced innovations trying to keep up with this targeted treatment development, and also, and most importantly, at the end of the day, the patient outcomes and their experiences are improved. And that matters most to me.
I first heard the term personalised medicine over 20 years ago, and not a lot had seemed to happen for a while. Maybe it's under the surface. But what I'm really hearing is that rather than, okay, you've got this particular cancer, particularly breast cancer, this is the pathway you're going to go down, and we know that certain people respond and certain people don't respond. What I'm hearing, and please, I'd like to expand on this, is rather than this is your cancer, is what we're going to do, this is you and your specific circumstances, and therefore we can tailor to your particular situation?
So you've absolutely hit the nail on the head.
Okay.
So, we used to have a one-size-fits-all for patients, and now we're coming into this realm where a patient, we can individualize their treatment based on their risk and their cancer mutations. And this allows us to really improve their outcome and also their experience and their cancer journey.
Okay, so in turn, if somebody comes in, they've seen Saud, they've had surgery, they're now coming through, they've never had genetic testing, is that then going to be done as obviously part of the receptors, but as part of the treatment journey to determine perhaps what sort of agents are used?
Absolutely. So breast cancer, as Saud alluded, is a cancer that is managed by a multidisciplinary team, which is the underpinning of best practice. So usually these patients come in first through an MDT or multidisciplinary team that the breast surgeons, the radiation oncologists and the medical oncologists and nurses attend. So often the genetic testing is done by the surgeon. So by the time they come to us, we have the information available, and it allows us to make these critical decisions in terms of treatment options. Now, in the rare event it doesn't happen at that level with the surgeons, when they come to us, we are then able to do the testing and then navigate based on the results of that testing. So I think that, I just am excited to be in the place I am because of this advent, and it's changed practice dramatically.
So what are these PARP inhibitors, and what does PARP actually stand for? Sorry, I'm showing my complete ignorance here, but it is a new one to me.
So I'll do it quite simply because I like to look at things simply. So if we look at a cell as a construction site and that is continuously sustaining damage, there are two crews that repair damage on that construction site. So if we say crew 1 is the PARP crew and crew 2 is the BRCA crew, we know that, say, for example, the BRCA crew gets tired and steps out, the PARP crew will step in and repair the cell, so the cell continues to exist. Mm-hmm. Now, when you have a BRCA mutation, the cancer cell, the BRCA crew, is permanently out of work, so it doesn't exist. So the only crew on site is the PARP crew. Now, if we do a PARP inhibitor, which takes the PARP crew out, both crews are taken out, so there's nowhere to repair the cell damage. Now, traditionally, the PARP crew repairs single-strand minor breaks, and the BRCA crew repair major double-strand DNA breaks, right? So if you take those two out...
So they're both doing genetic repairs.
Correct.
Okay.
So if you take both of them out, it creates a situation of what we call synthetic lethality, and that cell dies. Now, the other beauty of this is that this is targeting that mutation in the cancer cell. So normal cells, which can be affected by cancer treatments like chemotherapy, are not affected. So it's a very targeted treatment to the cancer cell, and it doesn't spill over into normal tissue. So the side effects are less than what we would do for something like chemotherapy, which hits all body cells.
So we really almost have now a laser-like focus on the
Absolutely.
cancer cells. And look, this is a statement of the problem in inverted commas with, I suppose, radiation therapy and chemotherapy is I'm trying to think of a better term, but the term that's been used is blunderbuss. There is a lot of collateral damage, and less than years gone by, sure, but this is really targeting at a cellular level. So to access these medications, again, are there specific sort of requirements? I'm assuming that they're only helpful in certain individuals as well.
Yeah, so the way the Australian healthcare framework is arranged is we've got access to these medications and they're highly subsidised, and this provides equitable care for patients. But there are restrictions as to when we can do it. So the BRCA1 and BRCA2 mutations are across the most responsive group. And once we establish there is a mutation, depending on the cancer, there are PBS codes that will meet. You have to meet the code criteria, and then you can get the drug at that highly subsidized cost for that patient. And I think that has just created this very equitable healthcare system where we're providing, excellent care to patients and giving them a personalized treatment plan.
Yeah, and I mean, it really does sound like if we want this laser focus, then we want the laser focus to be where it's actually going to be useful and necessary, not just that it's a laser. This is quite incredible. Saud, obviously, knowing this is coming after, or potentially coming afterwards, I mean, how is that affecting your role at the start as a surgeon in terms of how you might approach surgery in some of these patients?
Yeah, so the new guidelines actually had a big impact on breast surgery. So we see like two groups of patients. So we see patients who have the gene mutation and haven't had cancer, and we see breast cancer patients whom we send for mainstream genetic testing now. So we are able now as a surgeon to initiate the genetic test rather than waiting for genetic counselor to do that. And then the treatment is actually, as Sanjana did mention, is personalized to those patients. So whether the patients did have breast cancer or doesn't have breast cancer, we tailored the surgery according to the genetic test results. So it's just help us to define the surgical pathway in a more clear way. Especially for breast cancer patients, I would say, because, if the patient does meet the criteria to have the gene test, in the past, we, for example, can offer breast-conserving surgery, which is the surgery that is we do in about 70% of the time instead of doing full mastectomy. And then we wait for the test results to come back, and then if the patients will be tested positive, then that means another surgery. But now with the rapid turnaround time, if I'm seeing a patient with a breast cancer who actually meets the criteria, I can now talk to Kim, and then I can initiate the mainstream genetic testing, and then if I can get the results within 2 to 3 weeks, then that's actually can be very helpful, because now the patients can have like one surgery instead of doing like the small surgery first and then come back and do the big surgery later. It also benefits Sanju as well, because if as Sanju mentioned, if we initiate the mainstream genetic testing from our end, like from the breast surgical clinic, by the time the patients have the surgery and we've already got the gene test, then the patients can move to the next step, which is the systemic therapy. But then the patients will get the personalized treatment. So it's actually a new era now. We're not used to order gene test, but we're quite really enjoying that, because we feel, as I mentioned, it's a very collaborative now work. We work with the medical oncologist, with the genetic counselors. It's all to deliver like a really like a personalized treatment to the patient.
So as part of this, and you've all, I suppose, touched on it in different ways, are there these pre-meetings where, all right, we've got the patient who's sort of lining up, and there's almost like a program mapped out at the start? I mean, obviously, going to be guided by what you find as you go, but is that where we're heading, Saud?
Yeah. So
or are we there?
look from my end, like for example, for those patients who are breast cancer patients, any breast cancer patients, we discuss their treatment in what we call it the multidisciplinary meeting, and we have those meetings in every tertiary hospital, whether public or private, and this is on a weekly basis, and this is when we kind of finalize the treatment plan, and the genetic testing is part of the tools that we use in the decision making. For the patients, for example, who don't have the cancer but they have the gene mutation, test positive. For me as a breast surgeon, so we take those meetings we have what we call it oncoplastic meetings, in which we sit with our plastic surgeons colleagues, and we talk about, so from my end, we talk about different mastectomy options, and then we discuss with our plastic surgeons about different reconstruction options. So that test has actually really helped to streamline our treatment plan. And then by the time that we see the surgeons, because knowing this test results, we can actually discuss with them a specified treatment plan.
Okay, so again, we're pulling it back to this. This is not, you've got this treatment, therefore one size fits all. Yeah. We are now tailoring an approach to you in particular. I suppose that brings me to one next point, which is if people come in to see a GP and are sort of asking about genetic testing, and I suppose specifically in this area, what can I sort of usefully tell them?
I don't know, Kim.
Look, I'll have a crack.
Yeah.
Look, the challenge here is that under current Medicare rules, GPs aren't able to request Medicare-funded testing in this setting.
That probably makes my life a little bit easier in some respects.
Look, so it generally means that there needs to be a referral onwards.
Okay.
That's not to say it's not important that GPs understand the basic principles of this testing and why we do it, because they can actually have a conversation with a patient before referring about why they might have the testing, what the result might be, and even sort of prompting them to collect important family history information before they actually see the specialist, which all helps them to guide what testing they will or won't request.
Now that's something we were chatting about a little bit before we came on air, as it were, is this concept of strong, in inverted commas, family history, and what that, if anything, means, but also potentially the power of words for the better or the worse.
Yeah, so, I mean, look, I see this in my practice, and there are lots of women who comes and, the first thing they start with is, I've been referred to see a breast surgeon because I've got a strong family history of breast cancer. And I think we just need to probably define this. And probably Kim can give us some insight, but like, to my knowledge, for example, unless this is changed, is I would say category 3 risk or a strong family history of breast cancer is used to be defined as, 3 family members from the same side of the family and first or second degree relatives, and then one of them had a high risk criteria, which is breast cancer under the age of 40 or a bilateral breast cancer or ovarian breast cancer or a male with a history of breast cancer. So it's sometimes when a woman comes and being told that you've got a strong family history of breast cancer, and then we explored this a little bit and we found like one family member.
Yeah, so there's no real definition of strong as such.
Yeah, so maybe.
One thing also, Sanjana, you was talking before we came on air about male history tending to be a little bit dismissed.
So I guess for me, the biggest take home for GPs are that there are red flags, high risk red flags, right? So like Saud alluded to, early onset is a red flag. If you've got bilateral disease or bilateral breast in the same patient, that's a red flag. If you've got the history of multiple different primaries, that raises the risk of Lynch syndrome. So I had a patient with Lynch syndrome that had 7 different cancers in their lifetime. The other thing is, I think there is a misconception where people feel that family history is driven by the maternal line. And I think people need to understand that it is not, you can get it down the paternal line, that actually these genes like BRCA1 and BRCA2 and PALB are in autosomes, they are non-sex chromosomes. So it can come down any line. And I think that's really important to understand. And I think the two big take-homes is to take a detailed family history for GPs and then refer appropriately.
Totally agree with that.
Yeah.
And just to put it, I guess, into context, breast cancer is common. It's not necessarily going to be because of an inherited susceptibility that one of your family members has it.
So, and that gets to another point that we were chatting a little bit about on air, sort of presence of gene versus presence of cancer is not identical. So is that sort of also a bit of a misconception that if I have a gene, I'm going to get cancer? If I don't have a gene, I've got this force field around me? And how do those discussions work?
So I guess for me, patients come to me and say, oh, well, I've got a BRCA mutation, so I'm going to get cancer. So what I say to them is, yes, there's an increased risk, but it's not 100% certain that you are going to develop the cancer. And there are things that you can do to minimize your cancer risk and give them ownership of things they can do to make good lifestyle modifications and risk reducing things like exercise, diet, and quit smoking and limit your drinking. And I think that's really powerful to give patients ownership. But understanding that it's not 100% certain you're going to get cancer, it just means you are at an increased risk.
Yeah.
And we actually have ways that we can look at minimizing the risk or screening more frequently or doing risk reduction surgeries.
I mean, there is precedent for that, I suppose. Like, there's heart disease in the family. Does that mean I'm going to get a heart attack? Well, yeah, maybe you're at increased risk, but you can modify that by, not smoking, doing some exercise, managing your sugar and cholesterol. And I suppose with cancers, we've never really quite had that approach other than again, one size fits all, don't smoke, don't drink too much, don't get out sunburned. I want to throw it open now a little bit more to... Yeah, go on, Sam.
Sorry.
No, that's... I usually say, the lifetime risk depends on the specific gene as well.
Yes.
Because, it's statistically, I would say, women who have pathologic mutation in one of the breast or cancer predisposition genes, breast or ovarian cancer predisposition gene is between 20 to 80%, roughly speaking.
Between 20 and 80.
20 to 80%.
That's a fairly wide margin.
Yes,
yeah.
and the reason is because every specified gene has its own risk. So women who have a BRCA1 gene mutation, and Kim can talk more about this.
Saying all the right things.
Like the woman with a BRCA gene, between BRCA1 and BRCA2, there is a difference in the risk category. And then if they have the CDH1 or the PALP or the ATM genes, all these genes can cause cancer, but not at the same risk. And the other thing I tell those women who refer to us is risk reduction surgery or mastectomy doesn't mean that the risk is completely eliminated. So that's also important. Like having a mastectomy doesn't mean that your future risk of having cancer is not going to be 0%. It is dramatically going to be reduced, maybe 90% of the lifetime risk, but it's not 0%. So, sorry, Kim, I know this is...
Oh, no.
But what you said there reminds me, many, many years ago, I heard a talk, and this was, I think, when even epigenetics was maybe coming on the horizon. They said, look, genes, presence or absence of genes, but whether that gene gets switched on or not. And again, I suppose some of these factors, and you spoke about that, Sanjana, the exercise, the not drinking too much, influence whether the gene gets switched on, whether the gene that's there gets switched on or remains off.
So I think, Joe, breast cancer has changed. So we actually, you've got the treatment phase, And then once they complete treatment, they move on to what we call survivorship phase, which is where you're getting a patient back into their new normal, because they never go back to who they were before the cancer, but you're getting them back to the new normal. And one of the biggest aspects of survivorship is looking at all these different risks and trying to modify them and take an active step to discuss it. So I think survivorship can be done well. And I think that if we do that we can contribute to reducing risk down the track. And it also gives the patient a powerful ownership of their condition.
Okay. So this has all been excellent. As I said, I've learned a lot today. This has been really good, and I'm sure all the listeners have as well. As we've moved to look to wrap up, are there any particular misconceptions that any of you feel need to be sort of hopefully dismissed, or that people should be aware that there are myths out there?
Risk reduction mastectomy it's actually reduces the lifetime risk of breast cancer for women who have the gene mutation by 90%, or maybe 90+%, but it's not 100%. So that's a really important thing. That doesn't mean that surgery remain probably, being biased, the best intervention, or in addition to the lifestyle modification that Sanju did mention, and the mastectomy, any type of mastectomy will have the same risk reduction, like whether it is a nipple-preserving mastectomy or skin-preserving mastectomy. There is some concern that nipple-preserving mastectomy probably will increase the lifetime risk, or it doesn't really reduce the lifetime risk as nipple-sacrificing mastectomy. But I would say all the studies showed it's the same. So my message is, number one, mastectomy can significantly reduce the risk, but it doesn't make it 0%. Second is any mastectomy, whether it's a flat mastectomy or skin-sparing or nipple-sparing mastectomy with reconstruction, all have the same results. Yeah.
And again, happy for anybody to pick this up. What would be a sort of an ideal patient journey?
At least for me, and I'm coming from a medical oncology hat, is to do the genetic risk identification early.
Early meaning in the treatment phase?
As when patients come into contact, we want to do that early. And then we want to have this very coordinated multidisciplinary care that is developed. And we're looking at introducing these personalized risk reduction, whether it's surgery or whether it's these targeted treatment. And I think you need to break it down into 4 areas, where you go early testing, then we look at diagnosis and a personalized kind of care plan. And then you look at treatment options, whether it's surgery or whether it's systemic treatment. And then we go on to your recovery and what I term as survivorship, and how that is used in these patients with genetic mutations.
Okay. Look, normally when we finish, I ask the guests if they've got 3 key messages. What I might do today is we do want 3 key messages. Can I ask you each for one? Like, there's really one thing out of all of what we've discussed today that you'd like the listeners really, like, if you can't remember anything else, remember this one. And I'm sure they'll remember a lot of it, but this one, really a key message.
I guess from my perspective, we've been talking about the testing as though it's a very black and white concept. You test, you find something, you test, you don't. That's not necessarily the case. We get sometimes uncertain findings.
The grey zone.
And there's also an appreciation that just because we don't find something on the test that we do doesn't mean or it doesn't exclude the patient has a genetic susceptibility to cancer. It just means we haven't found an obvious reason for it yet.
So if I can, I've got 2 real big take-homes. So we know that inherited cancers are between 5 to 10%, right? So 90% of the cancers will not come with that family history. So just for people to be aware that not everyone's going to come to you with that family history. And I think that's really powerful. And then the second thing is people have a misconception that, nothing can be done. And I can say in this current era of medicine, that is categorically incorrect, and that there are lots of things that can be done if we understand risk, whether it's treatment, whether it's their follow-up, whether it's extending to their family, and we're looking at screening and trying, because it doesn't just affect the patient, it will affect their family members. And we can affect their journeys as well as the patient. So it sort of has a knock-on effect.
Saud.
I guess for me, I probably have two things to say. Is first, for as a take-home message to our listeners, is if there is any concern about the family history, or if you're not really sure whether this is a strong family history or not, there is what we call the high-risk clinic. So in any breast unit in a public hospital, there is a high-risk clinic. And this is run by a highly specialized breast physician. So they can actually do all the assessment. They can go to the online algorithm, and then they can give the right advice to to your patients. And they can initiate a referral to the genetic clinic. They can initiate a referral to a surgical clinic to discuss treatment options. So I would really encourage any of the listeners, any member of the listeners, to consider a referral to a high-risk clinic, because they are specialized. If they feel that they're not really sure about the risk category of their patients.
Yeah.
The second thing is, I would say, probably for those patients who are aware that they've got the mutation, but they're not sure whether they will like to consider having a risk reduction surgery or not, which is a really big decision. And then they just choose to have like a, let's say, annual surveillance or regular follow-up. They usually have their annual surveillance through the high-risk clinic, but they also see their GPs quite often. And I would say, while there is no universally defined optimal age to consider the risk reduction surgery, but and it's always hard to find this balance between maximizing the risk reduction and at the same time, minimizing the risk reduction and at the same time maximizing the lifestyle. Is most of the literature has looked into the risk of cancer will go exponentially high after probably the age of mid-30s. So after mid-30s, maybe the GPs can do more counseling to those cohort of women to consider really either chemopreventative medications or risk reduction surgery, rather than they stay exposed. Interestingly, I think Kim can help with that. If those women, if they make it to the age of 70 without having cancer, they probably outlived their risk. Is that right?
I think that's a fair comment.
Yeah.
Yes.
Okay, so there is something to be said for getting older after all. I'm pleased to hear that. All right. Look, this is clearly a rapidly evolving, it's a cliche, but a rapidly evolving space. And I suspect if we got you all back in 12 months and 24 months, we won't, and I suspect in 10 years, we won't even recognise this field. So this has been really, really informative. So Kim, Sanjan and Saud, I'd like to really thank you all for coming in and sharing your knowledge on the Medical Forum podcast today.
Thanks, Joe.
Thank you.
Thanks, Joe.
Thanks, Joe. Thank you.
Thanks for listening to the Medical Forum podcast. Please follow and encourage your colleagues to do the same. And if you have information and knowledge you'd like to share and be on this podcast, contact the Medical Forum team.